Welcome everyone to another AVATA webinar. My name is Deb Bryant. I'm the marketing coordinator, and I will be your host for this webinar. Today, we'll take a look at inventory optimization, specifically as it relates to healthcare and pharmacy. Presenting for you today are Dwayne Hardiker, Managing Partner at AVATA, and Ann Nguyen, Consulting Manager and Solution Architect at AVATA. Just a few housekeeping notes before we get started. All attendees are muted throughout the presentation, which is being recorded and will be made available to you. Questions can be submitted through the side panel question box, and if time allows, we will address these questions at the end of the presentation. Otherwise, we will follow up with you directly afterwards. And now I'd like to introduce Dwayne Hardiker, who will go over today's agenda and begin the presentation. Dwayne?
Thanks, Deb. Welcome, everyone. And I would also like to welcome my highly esteemed colleague, Ann Nguyen, who has really been, for years now, deeply involved in architecting this solution we're going to talk about today. For many people, is really life-changing in the industry. We're going to go over very briefly about AVATA. We're going to go over some of the healthcare challenges and opportunities, and then the 5 ways to optimize inventory in the healthcare system based on the solution that we've devised over a number of years. And then some deployment thoughts, and then final thoughts. So let's start off with something a little bit light, because what we do know is when you're dealing with healthcare and you're dealing with inventory, there's not the room for error. You have to take it, not that none of us take our job serious. This is an industry that service levels are high, and inventory is thought of as cannot be short, even though we deal a lot of times with the shortages. The industry has come a long way in medical devices and technology and drugs. I'm not sure, and it has come a long way in supply chain as well, but I think there's definitely some progress to be made. So what makes AVATA relevant in this industry and in general? So AVATA's been around for a long time as a strategic consulting company focused in supply chain. We cover everything from the people and process side of it in a managing consulting perspective, all the way down to technology. In the technology space, we are an Oracle strategic partner. We focus only on the Oracle solutions, and that's what this solution is from a technology perspective built on. Let's talk about some of the challenges. So for many of you, this is not going to come as a surprise. This is more just kind of credentializing what we're doing up here, and that is, inventory in most hospitals represents around 40% of the system's operating expense, which, looking at P&L, is a significant number. And when you look at the inventory days of supply, obsolescence, and lead times, if you look at these things, managing inventory and reducing inventory or days of supply by just 1 day over the course of a year is a massive amount of savings at an individual hospital level, let alone a group of hospitals and network. And even more importantly, forecasting. Trying to understand what the forecasting process looks like in a both med-surg and pharmacy space has its challenges. But again, a small percentage in forecast accuracy improvement results ultimately in a significant inventory reduction. And that's what we focused on, right? We understand the challenges of managing inventory at a DC or central warehousing location, or at a hospital, at a storeroom. We're down to a par level. The challenges of a par level dealing with the fact that, hey, how are these things cycle counted? How often? Oftentimes the par locations are expensed items, so the inventory isn't readily available in the system. So these are all the complexities that we thought through over a number of years with our clients in the industry to develop the solution that looks at these different angles and really tries to optimize it. This is a two-part webinar. The end-to-end solution is a combination of planning and execution. The planning side done by AVATA, the execution side we partnered with RF Smart, which deals with, how are you executing the ins and outs, the moves, the cycle counts? Are you using a handheld device? Is that automatically integrated into your ERP? So again, today's webinar is focused on planning, though I hope this solution is just compelling enough on just the planning side that it'll definitely bring you back for the execution side, which again, end to end is what we know to be a leading healthcare solution. Why do we know that? Because we have the proof. So in a case study of one of our customers, highly complex environment, 7 regions, 26,000 stocking locations, 1.5 billion purchases per month, 223,000 items. The payback of putting in the planning side of the solution was less than 1 year. Less than 1 year, the payback. Forecast accuracy went up 8 points. Inventory reduction greater than 20%. Now, this is achieved without impacting service levels or making anyone sleep a little uneasy at night. This is taking a very mathematical, common sense, and cultural perspective on an age-old problem of inventory management in the healthcare. So what does the planning solution look like? Well, there's 3 large components: demand forecasting, inventory management and visibility, and replenishment. So these are 3 components that we call planning within our solution. And of course, what we've done over a number of years is optimize each aspect of these 3 components and also made sure they worked harmoniously together. So when you talk about analytics and data models and all that stuff that's part of a supply chain solution, you can't leave out, and for our solution, it also has 3 key components: the people and change management. Again, when you deploy a solution like this, it's going to impact a number of people's jobs and lives. It's going to impact the culture of the hospital, the culture of the administration, the culture of the DCs. So again, you got to think through this, and we're going to talk more about this going later on in the presentation. What we also look at is processes and policies, right? What we've run across over the years is a lot of these processes and particularly policies are antiquated. So you have to really look at those and challenge them on what makes sense. And then, of course, from a technology standpoint, we leverage the Oracle technology to deliver the solution. And, as you're going to hear me say multiple times, this is ERP agnostic. You could be on a Lawson ERP or a SAP or Oracle, PeopleSoft, JD Edwards, whatever the ERP system is, this solution can kind of plug into it. So let's talk about the 5 ways to optimize, okay? So again, hopefully you understand that inventory in any industry optimization is not easy. So we're starting from the bottom up. So step 1 is demand forecasting. actually anticipating requirements, and we'll talk about how we do that. Second, dynamic safety stock and min-max. And again, the word dynamic, not looking back, not static, but constantly evolving, continuously improving dynamic replenishment. And then last is the replenishment. 4 and 5, basic models, advanced models. And we're going to explain what this means and why there's this line there. So I'm going to introduce you a concept called step, stretch, leap. It's a concept that was introduced to me back in the Ross Perot days. If any of you are as old enough as I am to remember that. So the concept here that we've applied is start with a basic aspect of the solution. And again, this solution, while built on the Oracle technology, is already pre-built, pre-optimized, pre-configured, pre-integrated, right? So the solution already exists. But with anything is there's levers, business decisions that have to be made and levers adjusted. So the concept is step into the solution at a starting point that makes sense. Stretch your organization culturally, technologically, and then leap. Once you start gaining some momentum and you've carved out the metrics and you've seen movement in the metrics, continue to push and leap into some more advanced capabilities, okay? The beautiful aspect of this solution is whether you are a single hospital or just on the pharmacy side, or you're a provider with a conglomerate of hospitals to manage, whether you are archaic in your systems or pretty advanced in your systems, you can start wherever it makes sense for you, right? But again, one of the things we determine initially in our assessment is what is your culture? What are the skill sets of the people, right? When we start talking about stepping and stretching, it's uncomfortable. So we want to understand the culture. What does the executive support look like? What do the systems and data look like, right? Because any good supply chain, anything starts with analytics, people that understand analytics, can do analytics, and you have the data to support it. Nobody has the data to support it perfectly out of the gate. Nobody. But where are you on that spectrum? And then last is the objectives. Where are you at in your current processes, your current people, your current systems around this type of solution? Maybe you have something, maybe you have nothing, maybe you're starting over. But where does this fall in your company's objectives and priorities, right? That allows us to gauge how fast or slow we throttle things and how to phase it in and where to start in the step. Well, let's go ahead and leap right into the demand forecasting side. So demand forecasting in the healthcare has its challenges. So this started with using a very sophisticated forecasting engine. From there, we had some of our deepest mathematicians analyze the data, the industry, and really tweak these mathematical models. Everything from parameters of what the engine is to the different statistical models to combining the models in order to make it make sense for this industry. And one of the things that we had to look at is what are the different demand patterns for med surg? Okay, what are the different demand patterns for pharmacy? Again, you may have both aspects of this in your business or one or the other. And then patients, scheduling, OR scheduling. I'm scheduling a knee surgery and I'm going to need a knee replacement kit. Well, that's inventory. And I know that schedule didn't happen overnight. I know when I go to the doctor and I try to schedule anything, it's a month out, right? And in most industries, having a solid forecast a month out is pretty nice. And that's at least a month out. I just rescheduled a doctor's appointment and it bumped me out 3 months. Locations. So it's not only important enough to understand the demand patterns, but it's as they relate to different locations, right? What are the demand patterns happening at a regional DC, at a hospital, at a central warehousing or storeroom within a hospital, and then at the PAR levels? And then, as I just alluded to, what are the different attributes of the different items within your supply chain? From different types of item types, the ordering units, and we're going to talk about units of measure in a minute here, but actually plays a pretty significant role. So again, the whole idea is over a number of iterations, we've taken these different inputs and kind of optimized how to manage a statistical forecast to get the process going in the healthcare industry. Now with that, forecasts are always wrong. So what was absolutely critical in an industry that had a large number of parts, ordering units, that we developed a proper exception management system. And that is an ability to understand the outliers, when and where they happen at either a highest level, could be a category with the highest error that flags someone, take a look at this, why is this happening? At an item level, at a facility level, and then all the way down to a location level. So I want to understand, I get flagged in my system saying, hey, for hospital A, you've got some challenges with this group of items that are at these locations that don't look right. Drill into it and understand what happened. Did someone misinput a parameter? Did some bad data get introduced? Or did the process not get followed, right? The whole idea is give me that warning system early enough to react to it. Allow me to get it at an aggregate level and then drill down to the detail level as I need it.
So as Dwayne noted, you need a robust forecasting process, right? Because the input into optimizing your inventory is to get your forecast as accurate as possible. So put in place a really good process.
Thanks, Ann, and that's exactly right. One of the two key aspects here in this process is we want to support the data and analytics, right? But to do that, Ann just nailed it. You got to look at the people in the process, because it's not a process that's contained within one person, one hospital often. It crosses barriers, cross-functional, crosses the four walls. So again, it's really important to focus on what that process is, who needs to get bought in on that process, what are the level of approvals, and when are these approvals triggered? And we're going to talk a little more about that too. So inventory management. So now that we've got a solid demand forecast and a process that supports it. So the next logical thing is, okay, how do we turn this good forecast into a way to help manage inventory? And a little side note, personally, PAR replenishment in of itself in a silo is not inventory management. So what we did, again, following the step stretch principle, so keep it basic, is look at the visibility, right? Make sure, how are you getting visibility to the inventory? What's the frequency? Because if we don't know what's happening on the inventory, if we don't have visibility to it, it's really hard to plan it. This is where we'll talk a lot more in the second webinar with our Smart around the execution side of it, and really being able to tighten that up. Because again, that is such a key component. The better the accuracy, the more frequent the updates, the better we can plan. Segmentation, again, a concept that's permeated throughout the supply chain industry for a number of years. It's been part of the Gartner conferences over the last 5 or so years, is an important concept, because not all aspects in the healthcare supply chain is segmented the same, right? The simple one is if you do have pharmacy and med surge, you're not going to treat, plan, and replenish those items the same, right? It doesn't work that way. But even within med surge, you may want to look at the different item types, families, and locations, and look at the business rules and look at the math around that segmentation. And then, of course, setting up a strategic safety stock and min-max methodology that is based off of the statistics, the advanced statistics that we've talked about in the demand planning. The key here is dynamic. You don't want to use just usage at a par location, for example, to determine its replenishment or determine its inventory min-max levels. You want that as input, but you want to look also at what the statistics, what's the forward-looking forecast also as a feed into that input. You want this evolving. You want it dynamic. You don't want it to be set in time. You want it to move as your requirements move. Now, it doesn't mean that for a certain point of time you don't parameterize it and you don't have it static. But you're always looking at it, and when it does shift, you put that workflow approval in place to understand what that shift is. Via mine consignment, talk about segmentation. There are plenty of opportunities within the healthcare supply chain to look at a VMI, even internally, model, and then take it even further to consignment to move those dollars off your books. Not part of this discussion, but certainly something that needs to be thought about. So when you talk about inventory management, some of the things that we start with is our safety stock calculations, where we use forecast and we use different business levers in the solution to drive that. Projected months on hand target, carrying cost, order cost, cycle count, lead times, and ultimately EOQ. So again, several different parameters that go into what the safety stock calculation should be and how it should be optimized along these different business levers. These business levers are reviewed and they're adjusted. And they are also part of the data management side and exceptions of, hey, what are we looking at our carrying costs frequently enough? Are our lead times accurate? So again, this is where we would call a start, a more basic model. So along that basic model, carrying order costs are used to determine obviously EOQ, right, which is baked into the system. Months of supply and lead time are used to determine the recommended min. And then cycle count, lead times, and EOQ are used to determine the calculated max. Now, the math behind this is beyond my pay grade, and so we're not going to get into the math. But this is just kind of showing you the components that can go into it. And it's not a black box. You can see from the screenshots, based on your role in the organization, you may be responsible for one of these business levels or one of these inputs. And that's the visibility you'd have without being able to impact anything else. So there's kind of roles, responsibilities that are baked into the solution as well. And then cycle count, again, another call out to the execution side of this, right? When you're, again, a lot of par locations are expensed inventories. Therefore, to get the visibility to the on-hand levels, you're doing cycle counts. And so the importance of being able to do those cycle counts quickly, automated, and effective goes to the execution side.
And really quick, it's very dynamic because the user can basically update all of these parameters, business levers, and then you see that dynamically your recommended min-maxes are going to change. They also have the ability to input their own recommended min-max based on feedback too from other teams.
Yeah, and that's a good point. Nothing in the system, you're going to hear this more than once, nothing in the system is without review, approval, and the option to manually override as required and deemed necessary. So, and that takes us perfectly to our last bullet. The workflow, an automated workflow will route these changes, these min-max values for approval, and then integrate back to the ERP system. All right, now let's leap. Let's look at a little more complex algorithm, if you will, around the safety stock. So one can incorporate seasonality, right? I'm going to take a perfect example. I just had ACL and knee surgery due to a skiing accident. That being said, I'm a very good skier. However, accidents happen. But I wasn't going to schedule this surgery right in the middle of winter. I wanted to schedule it in the summer so I could be ready to ski the next winter. Now, I could be a one-off case, but if you look at the industry as a whole, there are definitely certain things that drive seasonality. If you look at pharmacy, right, there are certain medicines that are going to come up during different seasons of the year that are more, allergy medicine, for example.
You can also
and I also
incorporate
had a
flu
fun
shot, Dwayne. For
What
example,
was
the hospitals, flu shot. During the winter seasons, there's a lot of seasonality incorporated with flu shots. They basically track year to year how many flu shots are needed because that's a seasonal. That's during the winter seasons that they have to prep for basically the needles, the vaccines for flu.
And that's the best example yet. Yep, that's a great example, Ann. So again, now it gets us down to some business decisions around when does it make sense to use a more fixed safety stock calculation or a pure or a statistical, right? So I'm going to go back and contradict a little bit of what I said about keeping dynamic safety stocks. Again, there are reasons, there's business situations, there are events that would require you to look at more of a fixed safety stock. And if it's based on, highly intermittent demand or a huge forecast error, where it's really, you just can't get that stats engine to give you something, worthy of driving a statistical min-max based solution. Now, that these engines and these stats models have been highly, highly tuned, but there's still situations. So when you're talking about a more increased complexity, the statistical safety stack uses in this advanced model a service level and that forecast error. So these are inputs that were not part of the simple model or algorithm. And then of course, if you're looking at the fixed safety stock, you can actually input the min-max safety stock days.
And how do you determine what can be used based on either the stats or the fixed safety stock is you have a number of observations. For example, if the item has less than 6 observations, that kind of generates that the stats forecast is not going to be that good because its number of observations is really low versus an item that has like 20 or 30 observations, how many times it's ordered during the week, for example. So you can have an automated program that will basically determine that, and then it will basically select the method to use for safety stock for you.
Awesome, thank you, Ann. And again, there's flexibility, right? Part of our job is to determine what makes sense for which. Again, looking at safety stock in more of the, making that leap in a more complex environment, unit of measure plays a huge role, right? So here, the solution compares the different unit of measure conversions based on forecast and lead time, and provides kind of what is the ideal unit of measure by item and even down to the power location. And then the safety stock looks at and basically takes that into consideration. It becomes available for the optimal unit of measure or ordering unit of measure.
So
and
an example.
This goes out of my pay grade.
So let me add more context to that. an item for a hospital, for example, can be ordered in different unit measures. You can order in eaches, or you can order a box. You can order in a row, for example, like Band-Aids. So, to basically optimize your inventory and determine which is the most effective, what is the ideal unit measure to be ordered and held for safety stock? So we can basically calculate that, looking at all of the different types of unit measure that the item is ordered and has been used before, which one is the best unit measure to be held in safety stock, basically to optimize your costs and your inventory and basically have enough on hand. So just adding a little bit more color to basically the unit measure conversion. It's applicable more for the PAR because, again, you can order multiple unit measures, right? And maybe for a doctor might like to order eaches because, he says, I use a lot of smalls, for example, items size. So I just want to have like 5, 6 because I only have so many surgeries, versus several other doctors use size medium, so they prefer the box to make it more optimal.
And again, the math and algorithm behind this is highly sophisticated, but it is all rendered through easily digestible, Excel-like GUIs that allow you to interpret it and make those adjustments. But the important thing is all this advanced math happens so that the min-max the solution can recommend the min-max in terms of what that unit measure makes sense. You can review it, and then you can change it if required. Okay, so we've talked about demand forecasting and getting the highly advanced statistical models and all those required inputs into a good statistical forecast baseline. Again, it gets reviewed, it gets taken through a demand planning process, because it's not just one person sitting in a cube somewhere making the entire decision for all the hospitals. At the end of that process, you approve it, you lock it down, and then you use the outputs to then drive the different analytical engines around inventory management and the visibility. Okay, again, this will recommend what are the different safety stock options, what do they look like, what are the values. They will be routed for review and approval and updates. And the last piece is replenishment. So again, once those forecasts and min-max parameters are reviewed and approved, we take it to create that time phase kind of replenishment recommendation. Some may call it a distribution plan. And again, this crosses the entire network. So, again, we're taking demand all the way up front from patients and what's happening at the hospitals, all the way down to the items and locations. But now we're looking at the inventory, stocking points, and we're driving storeroom, point of use, and power locations based on forecasted usages. And in some cases, we will look at the historical usages as well, and coming up with that replenishment plan across the network. So this is kind of a quick view of one of the forms of what it looks like. Again, very Excel-like. And then, every step along the process, and again, you keep me hearing this message, it provides the ability to override. Nowhere are you handcuffed to just take what's happening by these algorithms and having to run with it. In fact, we absolutely discourage that. We put the processes and controls in place to drive that visibility and management of it. So again, you can see, you come up with that forecast with the basically recommended mins and max, and then we look at what the inventory is at the different locations. In this particular case, you're looking at a specific site and a warehouse. comes up with that kind of what's my projected available at each of these locations, and then determine, hey, do I need to replenish? Now, again, this is a view at a site level. You can look at this at multiple sites, at an aggregate across your network. So lots of different options. Now, taking it again into that leap, into the little more complex side, well, the left side isn't actually more complex. It applies for both the basic and complex models. Is, as I've indicated, you want to be able to update these business levers to determine the thresholds, right? When do I call something excess inventory and I want to see that? If it's below my min, when it's getting close to my min, when do I want it to trigger me, so this is so we provide the kind of data management capabilities to go in there and make these changes. But then looking at the back to replenishment, we'll review the recommendations for replenishment between sites based on excess and shortages and do a rebalancing. So this is important because I may have a power location that's out of something, but have a power location at the other end of the hospital that has an excess amount. So before I go requisitioning it from a central store, I may want to just transfer it. Now that may not make sense either. But similar situation, I may run out of something at a hospital, but have it sitting at another hospital, or have it at a DC before I go requisition it to the manufacturer. So the whole idea is give me visibility to use up excess where I have it to cover shortages where I don't have it within my supply chain network at the different nodes. So again, it provides that capability to look at this. It provides that information. And here's a piece that we haven't talked up until now, but I think is the cherry on the cake. And that is, not only do we provide this information, we're dollarizing it. So when we're doing these reviews and approvals, inevitably it comes down to the dollars, right? So this, and the particular window you're looking at, I can see my excess dollars and units, and then I can see my days on hand excess dollars. So like I said, by cutting out just a single day on hand, oftentimes result in a significant savings. And the whole idea, I've been saying this, and now I'm going to show it as proof is in the pudding, right? Nowhere in this solution does it force you not to override something. And in here, again, you can analyze and review these recommendations within a hospital or across, however the process dictates. But in this example, you can see that the par unit of measure override. So we're actually overriding in this particular situation the par unit of measure. Say that 5 times fast. That the system recommended. So, looking at kind of a summary of our healthcare solution, we looked at demand forecasting, the inventory management, visibility, and replenishment. And that's what we call planning. That is our planning solution. It's highly analytical, from dashboards all the way down to that exception management. From an aggregate level, which could be an item location, or a hospital to a PAR location. Or it could be, it can be reviewed and manually overridden. I think that message has been hammered home. It leverages the workflows to automate the processes and these reviews and approvals. It also provides the ability to keep an audit trail. So not only is my workflow, making sure these things are in a timely fashion being routed through the right approvals, people are seeing the right information based on their role and responsibility, they're given the ability to override and make manual adjustments, but then they have to actually put, why am I making this adjustment? So we can keep track of this override, we can keep track of this audit trail. So when I'm having to talk to the CEO or CFO and explain something, I can go back, to, look at these, why I made this decision a month ago. Or someone can see that further on in the workflow. Why did Johnny before me make this override and increase this stocking level? As you just saw, it provides both units and dollars. And again, based on your role and responsibility, not everyone will have visibility to everything. So not everyone's going to see necessarily the dollars associated with these. It integrates with any ERP, as we indicated, and it can also house that critical orphan information. So as we all know, I've never in all my years gone through any type of solution for any industry, and there not been data that's not properly represented within the ERP system. There's something that's housed somewhere else, whether it's on Susan's Excel spreadsheet, her Access database, or in a data warehouse, or whatever. So with this solution, we provide the ability to, with flexibility, house some of this orphan data, and in general, kind of provide the ability to maintenance this data easily and make those adjustments. But then again, route them through for visibility and approval. It pulls data from the ERP, but also pushes data back to the ERP. For example, in the example of the min-max settings, then of course integrates with the RF Smart for the execution side. So let's look at some deployment. So the solution at the end of the day is as good as whoever's taking it can absorb it, right? There's some really great solutions out there that fail because you took a great round peg and did not acknowledge that you're trying to stuff it into a square hole. So that's one of the things that first and foremost in our deployments that we look at in the solution is making sure we're aligning properly with those things I talked about earlier. And the biggest thing is change management. So again, no one likes to talk about the warm fuzzy, but if there's an industry that needs to understand the warm fuzzy, it's the healthcare, and that you are impacting people's lives, you're impacting their jobs. It's an industry of tradition and ways of doing things for a long period of time. So you got to understand what you're changing, how you're changing, why you're changing, and making sure that buy-in happens from top to bottom, bottom to top. So one of the things over the years that we found with success is select the right team. It's typically a cross-functional team. It includes the business. It includes IT. It includes the practitioners. I mean, it's not you take the best of the best because this is gonna make a big impact. Put the metrics in place. Identify the metrics you want to measure. Some of them you may be measuring today. Oftentimes there'll be new metrics. Where possible, benchmark. Take a benchmark of where you're starting because we're going to measure that benchmark. And then monitor that performance and continuously improve. So some final thoughts. Again, we hope this was compelling enough to attract you to attend, and you'll all get notifications on our second webinar around the execution side of it. This is a pre-built solution to optimize all those aspects that we talked about: demand forecasting, inventory management, and replenishment. I was asked recently, I just want to start with demand forecasting, and I may not want to go any further. Is that possible? Absolutely. Again, the whole idea of the solution is understand where you are in your journey, what your objectives and priorities are, what can the culture handle, and starting there. You may have a demand forecasting process and system that works great for you. Don't touch it. Leave it alone, because God knows it wasn't easy to get that to where it's at. So instead, you want to work on the inventory side. Sure, not a problem. So then that piece of our solution would be applicable, and that's what we would focus on. So it's not a take one or nothing type solution. And again, it comes with highly built out analytics, both simplistically and advanced, and takes you through that whole exception management within the four walls or across the entire healthcare supply chain. And as I said, it integrates with anything. And we're continually improving our own solution, right? Because that's the name of the game. So we do believe, based on the results, that it's built on best practices with proven results. And because all of you did attend this and took time out of your busy days, I encourage you. We do have a case study, a white paper out there that you can download at the link provided here. Take a look at it. Pretty interesting story. We are at Oracle Open World Conference and the Modern Supply Chain Conference as well. Come visit us, come talk to us. Of course, you can reach out to any of us if you want to know more about the solution. Deb, did I miss anything?
Dwayne, we have two questions that we might want to address, and I believe you may have answered one of them. And we got a couple more coming in, so we'll see how much time we have for these. The first one is, does your solution work for med-surg as well as RX?
Absolutely. It's 1,000 million %. Yes. As I had mentioned earlier, if you're just on the pharmacy side of the house, that's great. Then you can use that part of the solution. If you're just doing med-surg, you can use that part of the solution. The algorithms are different. They were developed, completely different. The math models, the processes, everything, they're different where they need to be different, and they're similar where they need to be similar. And if you have both sides of the house, then you can take the solution in its entirety and cover both med-surg and RX. So the answer is yes, emphatically.
Okay. How long does an implementation take, or how long until I see some value from the solution?
Oh, there's a loaded question. There's a loaded question. The nice thing is, for those of you joining or taking on a solution like this now, it's been developed over a course of years. So your implementation time frame is much smaller. But that being said, it depends. It depends on, are you doing it just for med-surg or just for pharmacy or both? Are you doing it within a single hospital or a network hospital and looking at a broader supply chain network? Are you taking just the demand planning solution, or are you taking all of the components? So there's a lot of factors that it depends. In reality, and Ann, you correct me if I misspeak here. I'm gonna shoot a little bit from the hip here based on what we're seeing, but if I were to have to gauge it from what we're seeing, I would say 6 to 12 months.
Yes, that's correct, Dwayne. That's a good timeline.
Right. Yep. But like I said, that all depends. Could we shorten it a little bit? Certainly. It depends on what variables you're looking at. Depends on the culture. Depends on objectives, priorities within the organization. But there are certain things that you can't get around, right? This is in a lot of ways a significant deviation from how business is being conducted today. And that's just for the planning solution, right? If you were to tack on the whole execution side of the house, then it's a different ball of wax. So I'm answering the question based on just the planning solution. Like I said, there's just lots of factors. Your data, how available and mature is the data? How well is it maintained today? And don't say it's good, it's great, because that's what everyone says, and it's never accurate. Any other questions?
There is just one last question. Would service level be an input to the safety stock calculation as well?
Yes.
That's an and question. Is that a yes, Ann?
Question.
I believe it
Yes,
is, right?
it is. It is.
Service level is an input into the safety stock calculation.
All right.
Correct.
Thank you, Dwayne and Ann, for taking your time today to present this topic for us. And thank you all for joining us. If you would like to know more, we invite you to contact us via email, visit our website, or follow us on social media. If you do have any further questions, you can submit those in the survey that will follow as soon as we close out. Thanks, everyone, and enjoy the rest of your day.